Good morning, everyone. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. And today we get to have one of my very favorite shows because it involves lots of Chief Medical Officers and infectious disease experts from across the city. We have 8 different CMOs and ID specialists across the metro and across Kansas, including myself and, of course, Dr. Dana Hawkinson, Doc Hawk. It's been about 9 months since we've had a status report on COVID, so we'll look at that. Plus, see what you can expect to have happen with the flu and RSV as we go into the fall. And after we hear from our physicians, we'll open this up to reporters in the community for questions. Members of the community should put their questions into the chat feeds in Facebook, YouTube, X, or email us at the Medical News Network at kumed.edu. Alexis Tell Sid will monitor those feeds for questions. Let's get started. All right, across the country, according to this COVID data tracker from the CDC, so you can see where the numbers peaked a while back and they went down, and now they're starting to trend back up again. We don't like the trends up, but if you compare it to other years and the trends and how it has bounced back, now the next graph, you can see it still looks like a small bump compared to those big peaks we've experienced before. The question is going to be, what's to come? And that's the one we don't really know yet, right? Then only time and lots of effort will give us that information. Now let's look at the heat map. Now, if you remember, we used to show this in the New York Times, and you can see there are hot spots out there. And the darker orange ones are the places in the country where there's just simply more COVID. And it's hard to know because a lot of times we have to follow hospitalizations now as opposed to public testing, so there isn't as much testing. So there's kind of a combination of both. But there are hot spots. Now, this map isn't quite as loud, if you will, as it would have been at this time last year. But it's never been as loud as it is in November, December, and January. So what's to come with COVID? And here's a really important point. Overall, most patients, people who have had COVID, because you've had COVID before, you've been vaccinated before, or maybe both, you do pretty well. But there are populations that aren't doing well. You know, I happen to take care of a lot of lung transplant patients in my practice, and I work with Barnes Hospital in St. Louis a lot in that regard. They wrote to us the other day and said they are especially concerned about this variant because in the lung transplant population, it's been really hard, and they've seen more death. This is not something that we can just blow off. So let's bring in Dr. Dana Hawkinson, the Medical Director of Infection Prevention and Control here at the University of Kansas Health System. Hawk, what are our numbers looking like now?
Yeah, so right now we have numbers of 19 in the hospital for active infections. They have gone up. Recently they were 14, then 16, 19 this week. But if we look back we know that about a year ago in October we had 40. As we went to January, our number almost doubled up to about 76 in the hospital. That's a recent peak. In July, we know that we had single digits, which we were all happy about. I think we had 2 at one point. And then since that time, we've had a slow increase. We were in the single digits for a little bit. And as I just said, kind of in the double digits now. Now we're up to 19. So hospitalizations have increased a little bit, but like you said, Steve, nowhere near what we have seen in the past. And even the rate of change or the rate of that increase is pretty low or slow compared to other peaks and highs.
But Hawk, what we do know is that the patients who are coming in the hospital who have COVID, especially if they're over the age of 65, I'm getting close, if they have other problems with their heart, their lungs, etc., they may still experience a really bumpy course.
I think that's it, and that's what we've been saying. This is now a disease of those at highest risk. So age, comorbid conditions like diabetes, like heart disease, lung disease, kidney disease, and of course immunosuppressed patients as well. It seems to really affect them in different ways. Even with vaccination, you can significantly reduce your risk of hospitalization and severe disease, especially if you are up to date with your vaccination. We also have Paxlovid, but getting that viral illness, getting any illness can really push those chronic conditions over the edge where you just need a little bit more care, you need a little bit more attention, and that's what we're seeing here in the hospital with most of these patients in the hospital with COVID-19.
All right, I want to turn to our panel now. I am thrilled to have this group back together again, and we've promised we were going to get together, and we haven't done that yet. So we're going to get that one. We're going to get that one going. Let me introduce really quickly Dr. Jennifer Watts, Chief Emergency Management Medical Officer at Children's Mercy, Dr. Mark Steele, the Executive Chief Clinical Officer at University Health Truman Medical Center, Dr. Chakshu Gupta, CMO at Liberty Hospital, and Dr. Gupta, you're going to make sure I say your name correctly in that first part in just a minute. Dr. Jennifer Scripture, the infectious disease physician at LMH and public health officer for Douglas County. She's been with us many times before. Dr. Cliff Jones, Vice President, Subspecialty Medicine, Stormont Vale Health, and Dr. Elizabeth Long, the CMO at Latha Health. Thank you all for joining Dr. Hawkinson and I this morning. Doc Hawk, I don't know why I said Hawkinson, good gosh. What I want to do now is first of all say, you've seen what the COVID numbers have been like at our health system. We're going to talk with all these folks and just have a conversation here for a few moments. And I'm going to start with Dr. Jennifer Watts. Jen, how's it looking there at Children's? What are you guys seeing for the fall? And you can broaden that out beyond COVID and talk about RSV and influenza in kids too. Mm-hmm.
Yeah, we are certainly seeing cases of COVID back in our hospital. We had a good stint in there where we did not have any COVID-19 cases, and we have our similar numbers to last year. Currently today, we have 5 patients in-house with COVID-19. That has ranged between 0 and 10 over the last few weeks. I think the more concerning thing for us in pediatrics is we are starting to see RSV as well. We had 3 cases on our viral testing. We are not testing everybody yet, but we certainly had 3 cases already in the last week. And so we know RSV is starting to come and starting to be in our area as well. As we see cases of RSV and influenza start to rise, that is where the children start to get sick and start to need hospitalization as well. And so we are keeping tabs on all of our viral illnesses right now. We're starting to see that increase because school is back in session and kids are all together in the same areas. And so that's certainly the concern for us right now.
RSV vaccine, are you guys doing it for kids?
Not yet. It's coming, but it hasn't come out just yet. We're expecting it this fall for the youngest kids.
All right, good. Thank you. Dr. Mark Steele, how are things over at University?
Hey, good morning, Steve. And things are going well. We currently today we have 8 active patients in the hospital, none in the ICU. We did peak out at about 17 a week ago, and as you described at KU, back in July, we got down to as low as 1, mostly in the single digits throughout July, and then in August, we started to trend up a little bit and get into some double digits. We did just recently have a COVID-related death. It had been quite some time before the last COVID-related death. In terms of our test positivity rate, we had been well below 5% most of the summer, but that also trended up, got up to about 15% like it did nationally. And here recently has trended just down below 10%. And like others, we have seen a tick up in employees being out with COVID, particularly over the last couple of weeks. And so that's kind of what's going on here at University Health. We have had a couple cases of positive flu here in September. We had a handful in August. So far, we've not had any positive RSV here at University Health.
All right, thank you, sir, and thanks for keeping watch and giving that great report. Dr. Gupta, how are things in Liberty? Okay, and I'm going to ask you, because I'm just going to full humiliating moment for myself. Say your first name again for me. You and I know each other, and I always screw it up.
Dr. Stites, you did an amazing job. It is pronounced Chakshu. And I always say if you have difficulty pronouncing it, just combine the words Chuck with the shoe, and there you got it.
All right, got it. Chakshu.
Well, good morning, everyone. I'm happy to represent the Northland on this esteemed forum. So just this past summer, we had several weeks with 0 inpatient with COVID. However, starting in September, we now see an average of 8 to 10 inpatients with COVID. Between our hospitals and over 7 outpatient clinics, we've had 25 employees test positive, and we're seeing an increase in patients both getting tested for COVID as well as testing positive for COVID, and that's throughout the Northland. Our test positivity rate had gone down to about 1% in the summer. It's now between 9 and 14%. The silver lining is that the illnesses have been less severe and ICU admissions have been uncommon. We have not had an RSV positive as yet.
So, Dr. Gupta, one of the things I know that you mentioned that Liberty is kind of representing the Northland, but in the past, you all have a lot of nursing homes you work with. Have you seen any impact on the nursing home population yet?
Yeah, that's a wonderful question. We have had some cluster of cases positive in some of our nursing homes and long-term care facilities, and we have done our best to support them. But again, those clusters have been small and essentially limited in scope.
All right, that's good news, and hopefully it stays that way. I am pretty nervous about it. We'll see. Dr. Jennifer Scrimshire, the infectious disease physician at LMH. Jen, welcome back. How are you?
I'm good, Dr. Stites. How are you?
I'm good, ma'am. And how are things, Dr. Scrimshire, in Lawrence and in Douglas County?
Not too bad. We currently only have one active patient. I know that I've seen several recently that have tested positive in recent weeks, but they're antigen negative. But only one active in the hospital currently, none in the ICU. Employees has been in the past using employee illness as a kind of an indicator for the community, since we screen them more now. We've had quite a few in August and into early September. We currently only have 5 out, but we have quite a number that have been positive or had other, influenza-like illness, some respiratory thing in recent weeks. As with Dr. Steele, we've also had a recent death. So, COVID still exists. It's still out there. It still causes severe illness, as does influenza. And so, my focus with my patients right now is get your updated booster, get the flu vaccine when it's available. I don't want to end up in another. I would like to have a nice, regular fall and winter respiratory illness season as opposed to the past few years. How about that?
Man, I would love to see that. Are you guys talking about masking at LMH? I should have asked Dr. Steele or Dr. Gupta that, but are you thinking about masking again?
I haven't stopped really with patient care. Me personally, we are not requiring masking. And I don't know that we would with non-respiratory illness patients or outside regular contact precautions, airborne precautions. But I haven't stopped because I spend a large amount of time in small rooms with sick people, and then I move on to other people who don't have great immune systems. So it's easy for me to not spread something until things get a bit more normal.
All right. Well, I know we haven't done that yet, although we are keeping a very careful eye on that and thinking about when that day may happen and what kind of numbers we would look at. Dr. Cliff Jones is the Vice President of Subspecialty Medicine, Stormont Vail Health. Dr. Jones? Oh my God, okay, that sounds like I just talked about Indiana Jones. Dr. Jones, what are you seeing?
Good morning, can you hear me?
Yes, sir.
All right, Cliff Jones, I'm subbing for my boss, our CMO, Kevin Dishman, who's in DC on business. We have currently 7 inpatients. We've been averaging between 5 and 10 over the past several weeks. We were 10 last week. Just looking at some of those charts and those patients, it has been about half to a little bit more than half are primarily here with respiratory illness, and they appear to be the usual standard increased risks if that's why they're in the hospital. We have had in the first part of September up to 20 of our staff and providers out with COVID illness, and it's down to 10 to 12 this week, so it's been varying a little bit. Not anticipating going to universal masking. It's our infection prevention plans will be focused on rooms where patients are either being evaluated for respiratory illness, including the other viruses, which right now we're not seeing. People have mentioned the odd case. We did have one case of RSV a couple of weeks ago, but otherwise we haven't seen it, and we're not seeing influenza.
All right, so so far the report's pretty good, but let me talk to Dr. Elizabeth Long, who's a CMO at Olathe Health, our Olathe Medical Center. Dr. Long, how are things?
Thank you, Steve. Things are good, but just like your graph that you showed earlier, we definitely had that dip over the summer months, and we just wanted to put this in our rearview mirror and say, hey, guess what? COVID is over. And unfortunately, yesterday we had the highest number that we've had in several weeks, which was 6. One is in the ICU, nobody on the vent. Our last COVID death, which had been kind of rare for quite some time, was in July. We are seeing some employees that are out with COVID. It doesn't seem to be as severe. One thing that I wanted to touch on is that our census yesterday was the highest in our history. So our census is also going up, and that always is an issue because a lot of the COVID patients, as we would remember, they stay in the hospital for quite some time. And so that ends up being an issue for that. So we're doing well, but certainly we're monitoring things closely and trying to do all the preventative things that we can for our staff as well as for our patients.
Yeah, so here's what I'm hearing, Hawk. The numbers are trending up, and sometimes up and down a little bit, as Dr. Steele mentioned at University Health, but the numbers are overall kind of growing. Not like it has in the past, but I also know in the past sometimes we've had a ramp and then all of a sudden a big pop. What do you think? Is there going to be a big pop?
I'm hoping not. I'm hoping with individual and population immunity, and individual immunity from vaccination, revaccination, obviously infection and reinfection will help protect those who otherwise may have been in there. And then the population as a whole, with having that. Unfortunately, we are still seeing those at highest risk, but I'm hoping and being optimistic in the fact that we won't see that big pop that you are talking about. The other thing that we have talked about and you have talked about is having that plan. So just as Dr. Scrimsher said, get that updated vaccine, but also have a plan. If you have symptoms, test early, and if you can, get on those oral antivirals, especially Paxlovid. That's going to significantly reduce your chance of going to the hospital as well.
So, Hawkeye, here's my next question for you. And I know what my answer is going to be. Are we going to bear our arms again and have our shots on a future Wednesday?
Yeah, absolutely. I think when the vaccine's available, I will definitely be getting an updated.
Right here on a Wednesday morning. We'll be doing it again.
Absolutely.
And we want to demonstrate its safety, its effectiveness, and we think it's the right thing to do for most populations. All right, so I'm going to bet, Alexis, that there may be some questions, but I've heard that there is a reporter on the line. Let's check in and see where we are with that. All right, Alexis Del Cid, what questions do we have from the community?
Dr. Stites, the questions are rolling in. We have a question from Sean who wants to know about timing. Sean wants to know, can I get my flu, COVID, and RSV all at the same time? And we're getting quite a few questions about the order and when people should get those shots.
This is going to be a good discussion. I'm going to turn to Scrimsher and Hawkeye to help us with this a little bit, and then I'm going to give my own input, which will probably be irrelevant. But let's first start with Dr. Scrimsher. Okay, ID doctor, what are you saying to people out there?
Yeah, the flu and COVID vaccine, definitely you can get at the same time. And for providers and people in general, when you have them in clinic or have them in front of you, get them vaccinated, both at the same time if you can. And it's easier for patients as well. You're there, get them both, you're done. As far as the RSV vaccine, I don't know specifically something where they're maybe recommending doing that separate just because it hasn't been tested, but in general it's going to be safe, and in general you can do them all at the same time. I just don't know that there's any specific data to speak to getting the RSV vaccine with the other two.
Okay, just so our public remembers, like if you get the DPT vaccine, it's not one, it's really 3.
Yeah.
And so we've combined vaccines for years. This is not a new thing. But Dr. Poland was our show, the director of vaccine research at Mayo Clinic a few weeks ago, and he was saying, give about 2 weeks between RSV and influenza because both could be associated with some similar side effects. Do you want to address that? Yeah,
we certainly got that information. The ACIP, the FDA recommendations are that you can co-administer these vaccines together. There was a couple instances of that Guillain-Barré or neurologic deficit after co-administration with 2 of those patients in those trials. But But the recommendation is that you can co-administer. If you can use different sites, it's okay. But I don't see any reason why you couldn't co-administer all three of those. The recommendation for RSV is you can co-administer with other vaccines. In addition, if we are talking about specifically the COVID updated vaccine and influenza vaccine, even since last year or before that, they said you can co-administer those vaccines together. In addition, there is a preprint I was looking at this week that actually showed that the actual peak and the duration of the high antibody levels was actually greater in those people that received a bivalent COVID vaccine along with the influenza vaccine on the same day. Now, what does that mean clinically? Does that have any outcome or improved clinical effectiveness? It's hard to say, but at least we have some evidence saying you at least have some higher peak or higher antibody levels when you actually do co-administer those vaccines on the same day.
So diphtheria, tetanus, pertussis, three actual different vaccines mixed together, not one vaccine for all three. That's kind of what we're saying right now.
Correct, but in our ID clinics, when we're looking at transplant patients or our HIV patients, we will administer different vaccines all on the same day, such as pneumonia vaccine, the Tdap vaccine, the hepatitis vaccine. So we do that regularly in our clinics with other vaccines as well.
And when people travel internationally, you may get multiple vaccines all at once. So it's okay to do that. It's okay to do that. Okay, Alexis.
Maggie would like to know, as she writes, as a person with many allergies to different meds, what are the side effects of the RSV vaccine for the elderly?
Great question. Dr. Kupta, I'm going to turn to you. What are you reading about the RSV vaccine and what's going to happen with the elderly? And then I'm going to extend that question and go to Dr. Jennifer Watts at Children's to hear about what we think is going to happen in kids.
Yes, Dr. Stites, from what I've been reading, it's fairly safe. Of course, with every vaccine, there is a small subset of people that may have either a local reaction or a more generalized allergic type reaction. But overall, the message I'd like to convey today through this forum is that vaccines are safe, they're effective, and they're helpful in preventing more severe illnesses. So please talk to your doctor and get vaccinated.
Dr. Watts.
Yeah, thanks, Steve. In kids, we're expecting the RSV to come out this fall. Right now, it's out for the elderly population, which does still impact our kids as well. The more people we have vaccinated to RSV, the less spread we have in the area, which in turn protects our children today. So we certainly encourage everybody to get the vaccine when it is eligible for you. For pediatrics, we're expecting it to come this fall. It will be targeted towards the youngest kids. That's who RSV typically affects and impacts the worst and is the most severe. So we are looking to that. It will not be rolled out until everybody is sure that it is safe and it is validated and tested, and we know that we can guarantee that we are, that we can recommend it to everybody. I will comment too about co-administration of vaccines. We've done this in pediatrics for years, and people that have concerns about it for their children should certainly have that conversation with their pediatrician. That's why they're there. They're there to help you figure out which vaccines you need, when you should get them, and the safety and efficacy of that. And so certainly to have that conversation with your pediatrician. Most pediatricians are starting to get flu vaccine in right now, and they're starting to give COVID and flu together. We expect RSV to come for that population here in the upcoming months as well.
Thank you. Alexis.
Question from Marie about her new baby. She writes, if this is the disease of the people who have pre-existing conditions or other risks, should I get my 6-month-old baby vaccinated for COVID?
Okay, I'm going to write back to Dr. Watts here.
Yes, absolutely. Well, the COVID-19 vaccine is safe for everybody 6 months and up. There is some nuances in the younger children that you have to get 2 vaccines if you haven't had it before, and your pediatrician can help navigate who needs 2 doses and who needs 1 dose. And so we certainly recommend it. It's very similar to flu in that sense. While kids that are that young are not getting very ill and being hospitalized, it does happen. and the vaccine will still decrease that risk for hospitalization. In addition, it helps decrease the spread around everybody else. So even kids that are around elderly members, when you have a new baby in the house, everybody wants to come see that baby, including grandparents. And so if they can be vaccinated and help decrease that spread, your child can be vaccinated, decrease that spread to any visitors or anybody else that may come. You're doing an impact to the entire population and not just your own child. So certainly talk to your pediatrician about any concerns you may have, but it is recommended for every child 6 months and above.
Okay.
Thank you.
Yen Liang has a. Go on.
You go, Alexis.
All right. Yen Liang always has great questions. He wants to know, judging from the current data, is it possible that RSV and enterovirus could potentially evolve into another global pandemic?
Okay, I'm going to turn to Dr. Cliff Jones, who I believe is an infectious disease physician as well.
I am, and I don't have a good answer for that question. I don't see, I think the question included enteroviruses, and there are many variants, some respiratory, some not, closely related to rhinovirus, which happens to be, the common virus that we're seeing in the respiratory panels right now. I think those will continue to prey on people with high risk due to underlying health conditions, the older patients, the people with congestive heart failure and COPD, and those are the people we've always seen even before COVID in our critical care units and respiratory failure. RSV also, before COVID, once we started having the respiratory panel, we were identifying it in older patients. Previously, we hadn't been tested. That accounted for a significant number of critically ill patients with respiratory failure in those risk groups. The most interesting thing I think that we all observed was the paucity of RSV cases during the first year and a half of the COVID pandemic, and it kind of came roaring back. But as a non-pediatrician, as an adult ID person, it seemed to be making the greatest impact on the pediatric population in our hospital and in the community.
Jeannie Schlotzauer would like to know if there is a big concern, doctors, about having enough staffed beds this winter. Is staffing getting better compared to 2 years ago?
All right, Dr. Long, what's your sense? How are things in Olathe with that?
So what we saw when COVID happened, just as a reminder, is basically a mass exodus from the medical field. And so censuses were going up, and so the staffed bed became a very important factor. You could have a bed, but unless you had somebody to be at the bedside, that bed did not count. And so what we're seeing is, and so what multiple organizations did was they went to contract labor. And so that seemed to be a really big thing, continues to be a resource, but most organizations are trying to decrease that because that is a major cost for that organization. And what we're finding at our place is that people that went off to be a traveler have now done that, and they want to come back, and because that's just not as great as they thought it was. So we are really trying to decrease that contract labor. Certainly, I think that continues to be a problem, wanting to attract the best talent that we possibly can. And as I said earlier, our census was very high, our record setting, and so that continues to be a challenge. But I do feel like the curve is bending a little bit on that as far as having employed instead of contracted help.
Yeah, and Mark, still want to take an answer to that, but then I want to hear what you have to say too. Ours is better. We staffed every bed throughout the crisis, but we had to use a lot of contract labor. Contract labor is very expensive. Fortunately, our contract labor has gone down. We've been able to hire more people. To Dr. Long's point, there has been a significant, the great resignation, I think people called it, and we certainly saw that in healthcare, perhaps more than in any other field. We have been slowly building back. Turnover is better than it was. It's almost back to pre-pandemic levels, and our contract labor is approaching pre-pandemic levels. So we think we're in better shape. The other challenge, though, is if a lot of people got COVID, it includes your staff. And if your staff are out with COVID, then you can't necessarily run every bed. And that's the other dilemma you face. Dr. Steele, how are things at University Health?
Yeah, much the same as both of you just talked about. I mean, we are improved, but we're not back to pre-COVID levels. And we still have challenges in certain areas. And certainly it wouldn't take much of an influx of new patients that would sort of tip us over the edge. So I certainly improvement, but still pretty challenging in some areas.
As I remind our listeners today, one of our challenges before was that Kansas City, a long time ago, had more hospital beds than it needed. We are not an overbedded community, and the state, rural Kansas, is definitely not an overbedded community, meaning that there's more beds than you need. So one of our challenges is when you get a lot of influx of a new disease like COVID. At one point, we had 250 inpatients with COVID. That's out of 700. That was about out of 800 beds. So almost a third of our patient population was here with COVID. That means you don't have beds for other patients. And what it ended up is, if you remember those discussions we had about the Mission Control app, we could watch and see how long people were waiting in emergency rooms, et cetera. We couldn't get patients in who had heart attack, stroke, sepsis, pneumonia, and other challenges. So there was an increased death rate. There's no question that death rate went up, and the life expectancy was shortened during COVID. And a lot of it had to do with the inability to access health care. And that was because both of the number of patients and the less staff. At one point, I know we have like 15,000 employees. Over 1,000 were out with COVID, and you're hamstrung at that point about what you can get done. And so, do we think that's going to come again? I hope not. I think, along with our ID folks like Hawkeye, he and I would both say, "Gosh, we're hoping the combination of host immunity because you've had COVID, vaccination because you've been safe, Paxlovid, which clearly works, we will not see." That kind of peak again. Cross your fingers. Hope we're right, Alexis.
I have a great question. We have a reporter who just texted in. Rachel with the Kansas Reflector writes, "Thank you for holding the meeting. With the new FDA approval, when will the updated RSV and COVID-19 vaccines be widely available for Kansans? And for the jump in cases, how are the numbers comparing to those from last fall?"
The jump in case is not as fast, so that's good. We like it. So we're seeing a little slow curve. We hope the slow burn doesn't turn into a rapid burn when people move inside and it gets really cold. Remember, that's the other big thing. People move inside, you see more disease spread. I don't think we're going to see it like that. But Hawkeye, the variants can shift rapidly as they have in the last few months. Number one. Number two, RSV or COVID vaccination is now widely available at CVS and Walgreens.
It is. Yeah, people, you can schedule there. We are still waiting here at the health system, hopefully within the next 10 days or so. The same thing with RSV vaccine isn't really rolled out. We're waiting, nationally for that. So it's a great question. We don't have a specific timeline, but we are hoping that it will be more available. But like you said, to the commercial pharmacies, it should be available to most of those.
Like influenza's out there. Well, vaccine and the monovalent COVID vaccine, the new vaccine, you can't get the bivalent one anymore. It's been pulled. And so we do have vaccination for both those two. And I think RSV is supposed to roll out, or may have just rolled out. One of our other CMOs I think it's in some pharmacies.
The questions are rolling in. We have more, just one after the other.
If you guys can hang on, we can go a little longer.
Janet Coy wants to know, with the rise in COVID and RSV and flu, are the hospitals going back to masking, especially in high-risk areas?
Okay, great question. We sort of talked about that a little bit. Let's just kind of go around the panel. We talked to Dr. Scrimsher about it. Dr. Steele, are you guys going back to masking?
No, I mean, we've not made any changes, just masking, obviously, with usual precautions.
Yep, Dr. Watt, Children's?
We are not making any changes at this time. We are currently masking individuals, though, that have symptoms. And when we go into rooms of any child that has symptoms of COVID-19, RSV, influenza, any of our respiratory viral illnesses, we are masking.
Okay, Dr. Gupta, Liberty.
Yes, so we have not mandated masking of our employees or of our patients or their loved ones. However, number one, if you're going to a high-risk area, we encourage they have to mask. If you are sick or exposed, then we ask you to mask for 10 years post-exposure. And of course, we totally encourage masking. I think it's a good idea if you have a sick patient and an elderly patient with comorbidities, we certainly encourage masking there as well.
Yep, Dr. Long?
So we are not considering mandating masking at this time. We do have masks available at all the entrances, and certainly I am seeing more masking, people just doing it. Certainly for the patients that are in isolation, that is something that we take our normal precautions with.
All right, and Dr. Jones.
No, we're not going to be universally masking. We'll continue to have droplet precautions for individuals in respiratory isolation status. As others have said, we have masks available for people who choose to put them on.
Yeah, and that's kind of where we are, Hawk. And I think, I believe there is widespread community transmission right now. COVID-19, clearly, the wastewater testing would tell us it's out there. Just discussions in my patient population say a lot of people have COVID-19 right now. We're not seeing the rise in hospitalizations, so it feels different at the moment. But if there's a rise here, we will go back to universal masking.
But I will say that out in the community and here at the health system, I have seen more people volunteering and wearing masks on their own, so care providers, but also people out in the community. So I think that's a good thing. It's always highly encouraged. It will help reduce your risk of exposure to pathogens as well, even if those around you aren't masks. So.
Yeah, 2 weeks ago, I was back on a plane, and it was felt so crowded to me. My mask was on.
Yeah.
I was going to see my sister. She's 70 years old. I was like, nope, I'm wearing a mask.
Joellen McGranahan wrote in. She says, I'm 70 with high blood pressure, no kids, no babies in my family. I will get the flu vaccine. I will get updated COVID. Do I need to get RSV? And why am I hearing so much about RSV now?
Great question, John. Dr. Scrimshaw, what are you going to say to folks there in Douglas County?
The reason why you're hearing so much about it is because we got a vaccine for it, a new vaccine, which is good and available for adults and that is effective. I'm just starting to broach those conversations with my higher risk patients, those who are immunosuppressed, and I will offer that to those people. As far as my normally healthy patients, I think it will be a while. I want to make sure that we have available supply for those who need it first, and then maybe reach out to some of those populations. But I am not being aggressive with that just yet.
Okay.
And I think the key here is that there are two populations that are especially vulnerable to RSV. One is a very young population. Dr. Watt can address that in just a moment. But in the older adults, especially those over 65, those with underlying conditions, those who are immunosuppressed, RSV can cause inflammation around your airway. When it causes inflammation around your airway, it can make it very difficult for you to breathe. It can also lead to death. And that's what we've seen in a lot of transplant patients. Lung transplants, I know, follow over the year. The cystic fibrosis patients will follow. And so I am grateful that there's an RSV vaccine. Hawkeye, as I recall the data, it reduced the risk of death by 80 to 85%. Not an infection, but the risk of death by 80 to 85%. That's a home run.
Yeah, absolutely. Remember, again, a lot of these vaccines don't really stop infection. It is what happens when you get infected. It reduces the severity of disease. Now, with COVID vaccines, we have seen a little bit of reduction in infection, but that is not the main point. It's exactly what you said, to help reduce the severity of disease, the chance of significant outcomes, especially death as well. But I would also echo Dr. Scrimshaw's point. Yeah, we're talking about it because it's new. It took 40 plus years to develop a vaccine to RSV, a disease that particularly affects the very young and very old. So it is very important. Remember, that is what Dr. Barney Graham, before he went to work on the COVID vaccine, which took, 10 months, 12 months to work on, although built on decades of science, that is what he was working on first. So it is very exciting that we do have this. And of course, it is safe as well as effective.
And Dr. Ross, in young children, this is a home run too.
Absolutely. Every year we have children that die from RSV. We have children that are intubated on a ventilator to help them breathe. Every year we see this. Our ICUs start to fill up with RSV. And so the excitement for our population to get this vaccine is overwhelming. A lot of us are mind blown by this because this can change the face of pediatrics for the youngest individuals in the assistance of decreasing our mortality rate and decreasing our morbidity. So we are excited and anticipating a great rollout, and hopefully we see over time an uptick in receiving that vaccine.
Yeah, it's a big darn deal. Faith, hope, and science. Alexis.
Sandy Gilpin is asking a question that we've actually had several people ask this morning. What are the symptoms of the new variant? Are they different from the previous variants of COVID?
All right, great question. I'm going to toss that out to our team. Dr. Jones, what are you seeing?
Not seeing a lot of it, but the symptoms are very similar, and it's a respiratory virus with some systemic symptoms, but not. I can't differentiate it from previous strains.
You know,
Is pneumonia?
I think that's right, you know, and Dr. Jones is spot on. I mean, a lot of these symptoms are general for respiratory viruses in general, but it is very difficult to differentiate one from the other. And again, we also have vaccination, some immunity from infection in the past. So, you know, when you do get infected, you see that virus, your body sees that virus, you're going to start to have symptoms as well as your immune system kicks into gear. But really no significant difference in the symptoms. Now, there is a significant difference in the severity compared to Delta. But that's really about it. What they have found is since the variants have come along, really all the variants have the same risk of infection, risk of severe outcomes, really no higher risk of severity throughout the variants other than with Delta where they saw an increased risk. But again, Steve, just as you have continued to say, we have the safest way to help prevent those things like hospitalization and severe disease, and it's through vaccination.
And the rules of infection prevention control continue to follow you wherever you go and can keep you safe. Alexis.
Elizabeth has a question about Novavax. She writes, some people are waiting for Novavax. Can you talk about the difference between that and the 2 mRNA vaccines?
Yeah, actually, interesting discussion about it. I think it was I read yesterday or the day before. Novavax is also being developed for its vaccination against the current variant. Mm-hmm. It's a little different platform than messenger RNA, Hawkeye, and has been very effective. Mm-hmm. And for those people who are concerned about mRNA, is a great alternative.
Yeah, yeah, absolutely. We are still waiting for that rollout. I think we're still waiting for the FDA approval.
I think it is. I read yesterday, but I think they're really close, like within weeks.
Yeah, and it's a good option for people who don't want to go with the mRNA. Although we will say the best efficacy data continues to be with those mRNA vaccines.
Yeah, Dr. Scripps, anything different there? Okay.
Ruth Ellen has a question. She wants to know, is there an issue with the availability of the COVID vaccines? Because we had a conversation with our pharmacist and they had only 5 COVID vaccines and we're hoping for more at the end of September. This is a chain pharmacy in Lawrence.
Yeah, so, well, if it's in Lawrence, we're going to turn to Scripture in a moment, but I think they're just starting to roll it out, and so it may not be. But I know I've had a lot of people get vaccinated already at CVS and Walgreens, and again, we haven't gotten ours. We expect ours, I think, like maybe this week, maybe this Thursday or Friday, we should start getting them. Jen?
So I think the problem was, so we don't quite yet have the new bivalent, and the current, the previous bivalent that's been available we had to stop using it. We were told to stop using it, take it out of the refrigerator. So I think that's probably when this person visited their pharmacy. We were in that window where there's really not anything available until we get that new shipment of the new bivalent.
Monovalent, you mean? You keep saying new monovalent vaccination for COVID. Yep. Yeah.
Alex emailed us a question. Alex writes, I've had COVID 3 times. It was severe each time. Does this mean I'm more at risk for long-term general health problems or heart problems?
That's a great question. Hawk, help me out.
You know, what we have seen is that people who do have just once have increased risk of complications and new medical diagnoses down the line. So I would say yes. Now, can we quantify that? I don't know the data supports the ability to quantify that. But I will say from what we have seen in people who have had the disease, and especially severe disease, you are at risk of further problems down the line, like blood pressure issues, diabetes, things of that nature. So the answer would be yes, and it's just important then to keep tabs and updated with your medical professional, with your physician, and just monitor for those things like diabetes, high blood pressure, and anything else.
Lindsay has a question for all the doctors. Lindsay, it's a long question, I'm paraphrasing. She wants to know why hospitals aren't requiring masking with COVID prevalent right now.
All right, let me start with Dr. Long, and then we'll go to Dr. Gupta, and then after that, maybe 1 or 2 more questions. Okay.
First of all, I knew you were going to start with me.
Yes.
But second of all, I think this is a very difficult question because it kind of depends on what shoes you're walking in. There have been a lot of great things with masking, but then there's also been the downsides of masking as well. And I think that it's always knowing when to pull that trigger. And so I think that we know that that is a potential help if we need to get to that point. So then we start talking about, well, for flu, do we always need to mask during the flu season? And so the answer has always been that if you got the vaccine, then you didn't need to mask. And so I think instead of talking about the masking, and which is difficult, I think we really need to be promoting the vaccine, and that is really to get it at the source. And so that's where we're going to really try to promote. But certainly we can always go to masking if needed, but at this point we're not there.
Dr. Gupta, thoughts?
I think this is an excellent question and something that we certainly talk about in our weekly COVID meetings, as well as with our senior leadership and with our employees. So this is the balance we've tried to find. First of all, we encourage masking for everybody. So there is nothing against anybody taking a mask and putting it on when you walk into the hospital or the clinics. I think that's a wise idea. I think everybody should do it. However, there are some downsides to universal masking. One of them is there is some research, there is some evidence that it decreases the physician-patient interaction and collaboration. And so we have to be cognizant of that. The second thing is you can have a lot of people masking, but do they change masks between shifts? If you enter a patient that is a high risk for infectious disease, do you change a mask between patients? So there's a lot of these logistical considerations and resource allocation that we have to look into as well. The bottom line, I think it's a wonderful question. We certainly encourage masking, and we encourage vaccination.
And I just want to echo that. I think you guys done a great job answering the question, and I agree wholeheartedly. I think this is you go back to why do we mask? We mask for two reasons. A, I want to protect you if you're the patient, because remembering the COVID, you can be asymptomatic for 36 to 48 hours, shedding the virus before you have symptoms. And so, gosh, you may not know. So there's that consideration. B, I don't want a patient giving the staff or either physicians, nurses, anybody's staff, make them sick. Now we know if you're sick in the hospital, we're going to have you put a mask on, and we're going to put a mask on when we go in the room. But for routine, I do think it does degrade the ability to interact as well with patients, and especially if you're having personal conversation and you're having big conversations, to Dr. Gupta's point. So it is a trade-off. If a patient asks or wants to wear a mask, and when I go to my clinic, the first question out of our mouth is, actually, my first question is tell me your name and your date of birth, because we have to do two-factor identification now. But the second question is, would you prefer that we wear a mask? And the answer is, if the patient's wearing a mask, I'm going to put a mask on. But if it's a highly personal question, if we're going to have an intimate conversation, I said to them, this is going to be a hard conversation. Let me know if you still want to do masking. It's a trade-off. There is no question. But all parts of healthcare are trade-offs, and we have to do our very best.
I think we have time to squeeze in one more question.
One more. Okay, one more.
This is from Ruth Ellen, and Ruth wants to know, is the common cold still around, or are we renaming the common cold?
That's a great question. Yeah. I think the common cold is still around, Dr. Scribshaw, and I think that we haven't renamed it. COVID is distinctly different because of that spike protein. It is different. But for a lot of people, it feels like a common cold now. Don't forget to unmute, Jen.
Sorry, I lost my audio for a second. There's many viruses that cause the common cold. And coronavirus has been around for a long time. It's not ever not been around. We just have this mutation that happened that made this virus new to humans, and that's why it's such a concern. Can this happen with other viruses? Of course. Every hospital has a novel pathogen plan for things that come around that mutate that humans haven't seen yet. Will we see more? Sure. But there's many viruses around. They've not ever left. We just happen to not see them because we were all masking, which, masks work.
Masks do work.
Yeah. No, and I agree. And, that question, is the common cold, it certainly is around. All those other viruses that cause symptoms of the common cough and cold are still around. What we did see, obviously, when the first couple years of the pandemic, when we were masking a lot, we saw a significant reduction in other causes of the common cough and cold. But one of those viruses that was still present that we did see a lot of was rhinovirus. And that is probably because people were still touching things, touching them to their eyes, their nose, their mouth. So those other viruses are still around, but just discussions with KDHE just this week or last week. Also, we should note that in Kansas right now, the vast majority of respiratory viruses that are detected continues to be SARS-CoV-2. So we have significant reduction in those other viruses, including RSV and influenza at this point in time. So not a lot of high activity of influenza, but those other viruses are around and will continue to be around. Just as Dr. Scrimsher said, humans have been living with those viruses for many, many decades and centuries, so they will still be around.
Yeah, so I think if you have symptoms of cold, you could have A, rhinovirus, B, metapneumovirus, C, RSV, D, influenza, E, SARS-CoV-1, which is not COVID, R, which from the next letter, F, SARS-CoV-2, which is COVID, or F or G, whatever, one of the above. You could have any of the above, and we don't always know. Hey, this has been a great program. And I want to thank you, first of all, to all the providers, physicians who are on this line. Your time is valuable. We appreciate your commitment to public health. We appreciate you, and we appreciate all the collaboration we've been able to have throughout this whole pandemic. There are always silver linings. And, historically, hospitals so competitive, blah, blah, blah. But I'll tell you what, the level of cooperation and camaraderie and being able to work together has been just so impressive. So a big shout out to all these people and to all their hospitals. Thank you. We are blessed by a very, very, very strong hospital and medical community here in Kansas City. Thanks again to our audience. Thanks to all of you. Remember, we talk about it a lot. The combination of faith, hope, and science makes us all strong. And the rules of infection prevention and control help keep us safe. Keep your distance, wear a mask, cough into your arm, don't make others sick. We can all do this. Thank you. We'll be back next week.
A flutter in her chest that kept coming back every time she went for a run. It turned out to be the key warning sign that saved her life. I'm Alexis Del Cid. On the next All Things Heart, how this teacher got back on her feet after being diagnosed with a potentially deadly problem.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.